Welcome back to the deep dive. If you've ever experienced that dry, gritty, burning sensation that feels like sand trapped in your eyes, you've brushed up against one of the most common and, frankly, often frustrating chronic conditions out there, dry eye disease, or DED. But if you think this is just a minor irritation solved by a few drops, you are missing the monumental complexity of the system that is failing.
That really is the key. DED is so much more than simple discomfort. Our sources, they show that this is a complex, progressive, and, a multifactorial disease.
Right.
It hits hardest among postmenopausal women and the elderly. So today, our mission is to peel back the layers, literally, and unpack the high-tech, complex physiological machinery that governs the stability of your ocular surface.
And we have an incredible stack of clinical and physiological sources here. We're going to be moving right into the molecular mechanics.
Yeah.
We're aiming for a really comprehensive understanding of why DED becomes this self-perpetuating chronic cycle involving instability, hyperosmolarity, and inflammation.
Exactly. And if we can understand the complex failure, we can understand the strategic rationale behind the treatments. It all starts to make sense.
Okay, so before we dive in, let's get the language straight. I see a few different terms used in the literature.
Yeah, that's a great place to start. We need to standardize the language because clinical notes can be confusing. So dry eye disease, DED, that's the big comprehensive umbrella term.
Okay.
It just means inadequate tear volume or function that leads to an unstable tear film and eventually surface damage.
So what about the terms that sound a bit more academic?
Right. So the term you'll see a lot in older clinical literature is keratoconjunctivitis sicca, or KCS.
KCS?
Yeah. That's really just the clinical diagnosis for any eye that presents with dryness symptoms.
Okay.
Then there's xerophthalmia. This one is critical, but also very specific. It means dry eye that is specifically caused by a vitamin A deficiency.
Which affects the mucus layer, as we'll get into.
Precisely. And finally, Sjögren syndrome, or SS. This is a crucial one because it's a specific systemic autoimmune inflammatory disease. Dry eyes are a major feature, but the problem isn't just in the eyes. It's a systemic failure.
Perfect. So DED is the umbrella, KCS is the descriptive state, and SS is one of the big underlying causes.
You've got it.
To really appreciate the problem, I think we have to first appreciate the perfection of the normal system. So let's unpack this system. When we look at the tear film, we're talking about a microscopic environment, barely thicker than a thin plastic wrap, yet it's engineered for immediate, constant protection.
It is.
It's composed of 3 utterly distinct layers.
And the functions of these 3 layers are completely interdependent. If one fails, the whole system just collapses.
Wow.
The total film is incredibly thin. We're talking about 7.3 micrometers. But chemically, it's an absolute powerhouse. It's been shown to contain hundreds of different proteins, all working together.
So where do we start?
Let's describe them from the outside in.
Okay, so starting on the outside, facing the air, we have the lipid layer.
This is the thinnest layer. It's the outermost shield, at a shocking 0.1 micrometers thick. Its source is the meibomian glands, which, line your eyelids.
Right.
Think of this layer as the oil slick on the ocean of your eye. And its primary function is absolutely vital. It prevents the aqueous, the watery layer underneath, from rapidly evaporating.
What's it actually made of? It's not just simple oil, is it?
No, not at all. It's a really sophisticated dual-phase structure. You have an outer non-polar phase, which is made of waxes, cholesterol esters, and triglycerides. That's the heavy, waxy material. And then right underneath that, you have an interpolar phase, which is phospholipids bound to specific proteins called lipocolins.
Wait, help me understand that. Why 2 phases? Why not just 1 layer of oil?
It's all about surface tension and stability. That interpolar phase acts like a surfactant.
Surfactant, okay.
Think of it like a molecular handshake. It allows the oily layer to spread evenly across the watery layer without clumping or breaking up. If you just put non-polar oil on water, it just beat up. This 2-phase system ensures you get a smooth, unbroken seal.
And the mechanism for applying this is also fascinating. It's not passive. It requires active engagement.
It does. These lipids are not just sitting there. The actual physical movement of your lids during blinking is essential to massage the meibomian glands and express these vital lipids. The sources point out that forced blinking, a hard, intentional squeeze, can actually increase the thickness of this protective layer.
And that leads us to one of the most common modern causes of DED.
It does, the digital age factor.
Yeah.
Exactly. Infrequent blinking, which is so prevalent when we do focused near work prolonged computer monitor use, reading a book, watching a dramatic movie.
Right. You just stare.
You stare.
Yeah.
And that significantly reduces the delivery and thickness of the lipid layer. A deficiency here is what results in evaporative dry eye. The moisture is just burning off way too fast.
So if the lipid layer fails, that enormous middle layer gets exposed.
Yeah.
That brings us to the aqueous layer, which is 7 micrometers thick, so that's almost the entire volume of the tear film.
This is the workhorse of tear secretion. The vast majority, about 95%, comes from the main lacrimal glands, which are tucked away under your brow bone.
Yep.
With the accessory glands of Krauss and Wolfring chipping in the rest. And crucially, secretion happens in 2 different modes.
We have the basic resting mode and then the massive emergency mode.
Correct. The basic or resting secretion keeps the eye lubricated day to day, but then there is reflex secretion.
The emergency response.
Exactly. This reflex can increase tear output by an astonishing 500% in response to injury, inflammation, or sensory stimulation.
Wow.
If you get a speck of dust in your eye or if you start crying, that massive watery response is mediated primarily through the 5th cranial nerve, the trigeminal nerve, sending that distress signal.
And the composition of this layer is what elevates it from simple water to, biological necessity. It's a whole pharmacy of protection.
It is a complex biochemical soup, and it's tailored for eye health. Of course, it's mostly water and electrolytes, but the proteins are the real stars. You have IgA, which is a key mucosal antibody.
So immunity.
Yeah, providing adaptive immunity right on the surface. You have lysozyme and lactoferrin, which are nature's own antibiotics, providing powerful antibacterial activity. It's also loaded with growth factors to help with healing.
So it's doing mechanical cleaning, oxygen delivery, and fighting off invading microbes all at the same time.
Precisely. It provides atmospheric oxygen to the corneal epithelium, which doesn't have its own blood vessels.
Right, it's a vascular.
And it washes away debris. And here's a surprising nugget from the sources. Pro-inflammatory interleukin cytokines. Those are the messengers of inflammation. They actually accumulate during sleep when your basic tear production is at its lowest.
That makes perfect sense. Your system slows down overnight. The inflammatory junk builds up. And that explains that common symptom of waking up with eyes that feel a little rough or sticky before your first few blinks wash it all away.
That's the feeling. Now, finally, we move inward to the smallest, but maybe the most structurally critical layer, the mucous layer.
At only 0.2 micrometers, this is the layer that's interacting directly with the corneal surface.
And its source is primarily the numerous conjunctival goblet cells, which are these specialized mucus-producing cells distributed across the eye surface, with a little help from the lacrimal glands.
And it's made of mucins.
Exactly. The layer is made of high molecular weight glycoproteins known as mucins.
Okay, let's zoom in here. You mentioned earlier that the corneal epithelium, the surface of the eye, is naturally hydrophobic. It repels water. Why is the mucus layer so essential in overcoming that?
This is the great chemical converter. It's the primer, if you will.
Okay.
The aqueous layer, the water, it can't stick to a hydrophobic surface. So the mucus layer's job is to coat that water-repelling surface and chemically convert it into a hydrophilic surface, one that loves water. Mucins act like a biological detergent or glue, letting the aqueous layer spread evenly, maintain stability, and provide lubrication. If this layer fails, the water just beads up, leading to dry patches.
So deficiency here isn't a lack of water, but a failure of adherence. But it leads to the same result: surface exposure.
Correct. Loss of goblet cells leads to severe surface damage. This can happen from chemical burns, autoimmune disorders, or, as we mentioned, a vitamin A deficiency, which is where that term xerophthalmia comes from.
Right.
Clinically, when we use a staining dye called rose bengal, we're literally looking for areas where that protective mucin layer is absent or altered, revealing the exposed cells underneath.
The system is so fine-tuned, and it's clearly tied to our overall health. You brought up hormonal regulation earlier. Why is DED so strongly linked to things like menopause?
The regulation is highly systemic. Androgens, which we often think of as male hormones but are present in both sexes, are the prime hormones responsible for regulating lipid production in those meibomian glands. And crucially, estrogen and progesterone receptors are also essential for the normal function of the conjunctiva and the lacrimal glands.
That explains the spike in prevalence in older populations, then.
Exactly. As levels of systemic hormones decline, particularly levels of systemic androsterone sulfate and epiandrosterone sulfate, we see a strong association with dry eye syndrome. This isn't just a local plumbing problem.
No.
It's a manifestation of a systemic endocrine imbalance affecting the tear film's integrity. And understanding this systemic connection justifies specific systemic treatments like oral fatty acids that we'll talk about later on.
That detailed look at the tear film structure really sets the stage for the failure. The core realization in modern ophthalmology is that when DED occurs, it's driven not by one mistake, but by four core interrelated mechanisms that feed into a self-destructive loop.
This is the shift in understanding that just revolutionized treatment. The four cornerstones driving DED are 1. Tear instability.
So the film breaks up too fast.
2. Tear hyperosmolarity.
The tears become too salty.
3. Inflammation.
The body attacks itself.
And 4. Ocular surface damage. The physical result of all of it.
Let's focus on that second point, hyperosmolarity. We defined it as too salty, but why is that saltiness so destructive?
It creates a massive stressor on the cells of the ocular surface. Think about basic physics, osmosis.
Right.
If the tears on the surface become hyperosmolar, so too concentrated because the water is evaporating, they have a higher salt concentration than the epithelial cells of the cornea and conjunctiva.
That water follows salt.
Water follows salt. So the high salt tears aggressively draw water out of those delicate surface cells.
So the cells are literally dehydrating from the outside in under this immense osmotic pressure.
Precisely. This dehydrates and shrinks the cells, leading to cellular stress and eventual death. And when those cells die, they release pro-inflammatory signals, interleukin cytokines, matrix metalloproteinases, and this leads directly to mechanism number 3, inflammation.
And here we find the infamous vicious cycle.
This cycle is the engine of chronicity. Instability, often from a lack of lipids, causes hyperosmolarity. Hyperosmolarity triggers cellular stress and death. That stress signals inflammation. The inflammation, in turn, damages the delicate glands, the meibomian glands, and the lacrimal glands, reducing both aqueous and lipid output.
Which makes the tears even more unstable.
And you're right back at the beginning. It's a downward spiral.
The insight here, the real nugget of knowledge, is that inflammation isn't just a secondary effect, it's a primary perpetuator of the whole thing.
Absolutely. The data supporting this is huge. Inflammation in the ocular surface tissues is present in up to 80% of KCS patients. The revelation wasn't just that the eyes were dry, but that the dryness was fueling a chronic, microscopic autoimmune response.
Right.
This scientific realization is why treatment protocols shifted entirely, moving beyond simple artificial tears and making anti-inflammatory agents absolutely essential for long-term control.
Okay, so to categorize all this, clinicians used the DWS classification, Dry Eye Workshop 2007, which splits DED into two primary, though often overlapping, categories.
Right. Aqueous-deficient dry eye and evaporative dry eye. And we have to stress that in the real world, many patients suffer from both components at the same time, especially as that vicious cycle gets going.
Let's break down the aqueous-deficient dry eye category. This is the failure of water production.
This is categorized first by etiology. The most recognized is Sjögren syndrome, SS dry eye, which is an autoimmune destruction of the lacrimal gland.
Okay.
Then we have the non-Sjögren causes.
What are those common non-Sjögren causes that someone might encounter?
Well, there are primary causes like age-related changes where the glands just atrophy over time, or something called congenital alacrima, where you're born without tear production.
Wow.
More common are secondary lacrimal deficiencies. These can be inflammatory, like sarcoidosis, or due to infiltration by neoplastic disease. Systemic issues like AIDS or graft versus host disease also fall here.
And sometimes the gland works, but the ducts are just blocked.
Correct. Lacrimal gland duct obstruction from severe scarring diseases like trachoma or Stevens-Johnson syndrome. And finally, the category of reflex hyposecretion is huge and often overlooked.
This is where we talk about signal failure.
Yes. The signal pathway can be blocked in two ways. Sensory block happens if the cornea loses sensitivity, which occurs often after refractive surgery like LASIK, or with chronic contact lens wear, or systemic diseases like diabetes.
So the brain never gets the "we're dry" memo.
It never gets the memo, so the gland isn't signaled to turn on that massive reflex response. Or you can have a motor block where the signal to the gland is blocked, perhaps due to seventh cranial nerve damage or, critically, systemic medications.
This is the important point for our listener. The list of common drugs that can dry you out.
It's extensive. Antihistamines, beta blockers, diuretics, antispasmodics, and a lot of psychotropic medications can significantly reduce tear production. They act as a motor block and can tip a borderline patient into symptomatic DED.
Now for the second major category, evaporative dry eye. The water is there, but the lid on the pot is broken.
Right. We divide this into intrinsic and extrinsic causes. Intrinsic evaporative dry eye is mainly about the lipid layer failing. And the vast majority of intrinsic DED is due to meibomian gland deficiency, MGD, often associated with posterior blepharitis or skin conditions like rosacea.
But the other intrinsic cause is behavioral, which links back to our modern life.
The low blink rate. If you find yourself in a state of focused concentration, your blink rate can plummet from, say, 15 times a minute down to 3 or 4.
That's a huge drop.
It's incredibly destructive. The eye is exposed for longer, and the required mechanical action to express the lipids just fails. This is a common feature in Parkinson's disease and, of course, prolonged computer use.
And the extrinsic evaporative dry eye factors, what are those?
These are external stressors on the ocular surface. Vitamin A deficiency, chronic contact lens wear, and significantly topical drugs, specifically the preservatives they contain. If a patient is using preserved drops many times a day, the preservative itself, like benzalkonium chloride or BAK, becomes toxic to the corneal cells. It starts mimicking the damage of dry eye itself.
So to sum this up, whether it starts with not enough water, aqueous, or the water evaporating too fast, evaporative, the end result is always the same.
Always. Hyperosmolarity, inflammation, and surface damage. And we have to emphasize the role of environmental factors in accelerating this. Low relative humidity, air conditioning, wind, central heating, these external factors massively amplify the evaporative component.
So a person with mild aqueous deficiency can feel severe pain under the wrong conditions.
Exactly. It can be debilitating.
Sjögren syndrome, or SS, elevates DED from a local ophthalmological issue into a full-blown systemic autoimmune disease.
Let's focus on the severity and complexity of this specific cause.
Sjögren syndrome is a chronic, progressive lymphocytic inflammatory disorder. Basically, lymphocytes infiltrate and eventually destroy the moisture-producing glands, the lacrimal glands, and the major salivary glands.
And it affects women more, disproportionately so, often by a ratio of 9-to-1. Typically presenting after the age of 40.
And it can exist in isolation or be linked to other conditions, right?
That's the classification. Primary SS is when it stands alone. Secondary SS is diagnosed when it's associated with another connective tissue disorder, most commonly rheumatoid arthritis or systemic lupus erythematosus.
The classic clinical presentation is often referred to as a triad.
Yes, the classic triad is dry eyes, KCS, dry mouth, xerostomia, and sometimes noticeable parotid gland enlargement. But because this systemic inflammation can affect pretty much any organ, patients can also present with fatigue, joint pain, or even internal organ dysfunction.
Focusing purely on the ocular symptoms, what is the patient experience like, specifically for someone with SS?
They report intense feelings of dryness, burning, and grittiness. What characteristically differentiates this from mild environmental dry eye is the progression. The symptoms often worsen significantly over the course of the day, really peaking in the evening. They might also complain of blurred vision that clears for a moment after a blink and stringy mucus discharge.
And we discussed how lifestyle factors are potent exacerbators.
Massively. Patients will tell you that sitting near an air vent, being in a low humidity office, or trying to read for an hour straight without a break makes the symptoms nearly unbearable. Interestingly, while the basic tear production is severely compromised, the sources note that the massive reflex tearing response, the ability to cry or water profusely if stimulated, is often preserved, which is a key clinical distinction in the early stages.
When a specialist looks at an eye affected by SS, what are the definitive visual signs that stand out?
Well, we look at the overall ocular surface health. First, there's a frequent secondary association with posterior blepharitis and meibomian gland dysfunction.
Okay.
But the most definitive signs relate to the quality of the tear film and the extent of surface damage.
How does the tear film actually look physically?
We look at the marginal tear meniscus. That's the thin crescent of tears that pools along the edge of the lower eyelid.
Oy.
A normal meniscus is robust, about 0.2 to 0.4 millimeters thick. In severe dry eye, particularly SS, it becomes thin, fragmented, often less than 0.25 millimeters or sometimes completely absent.
And you can see debris.
Yeah. You may also see the accumulation of lipid-contaminated mucin debris, little particles moving visibly with each blink.
And what about the damage to the cornea itself?
This is critical and is revealed using staining dyes. We look for widespread punctate epithelial erosions, tiny breaks in the corneal surface that stain with fluorescein. If the disease is more advanced, we see filaments.
Filaments sound severe.
They are. They're tiny strands of mucus and debris attached at one end to the corneal surface that just drag across the eye with every single blink, causing immense pain.
Oh, wow.
These stain brilliantly with rose bengal. Even worse are mucus plaques, larger, semi-transparent white to gray formations that indicate a very severe advanced dry eye failure.
If these advanced signs are ignored, the complications become truly vision-threatening.
Unchecked, the hyperosmolarity and inflammation can lead to progressive epithelial breakdown, chronic non-healing ulcers, a process known as corneal melting, and potentially perforation of the cornea itself.
Which can lead to infection.
Yeah, it can also invite secondary bacterial keratitis, which is an infection requiring immediate and aggressive treatment.
Since this is systemic, diagnosis has to require more than just an eye exam. How do clinicians confirm SS?
We rely on systemic criteria, such as those established by the American College of Rheumatology, the ACR. The diagnostic findings generally require a cluster of objective measures, typically including evidence of specific autoantibodies in the blood, specifically anti-SSA or anti-SSB antibodies, alongside objective signs like a high grade of ocular surface staining.
And what's the definitive systemic proof?
That usually comes from a salivary gland biopsy. The finding of focal lymphocytic sialadenitis, so clusters of inflammatory cells attacking the gland tissue, confirms the systemic autoimmune nature of the glandular destruction.
And because SS attacks multiple organ systems, the treatment has to extend beyond simple eye drops.
Absolutely. The treatment involves ophthalmologists, rheumatologists, dentists. We treat the dry eye components, but we also manage the dry mouth, often using salivary stimulants or secretagogues like oral pilocarpine.
Right.
For patients with severe systemic involvement, the rheumatologist may prescribe potent systemic immunosuppression, sometimes involving biological agents like rituximab, to halt the overall autoimmune process.
We now move to the clinical investigation, and this section contains a huge reality check. The actual scientific measurements of dry eye often don't match what the patient is reporting.
This is one of the most persistent clinical challenges. There is, historically, a really poor correlation between a patient's self-reported symptoms of pain or discomfort and the objective clinical test results.
Especially in mild to moderate disease.
Exactly. A patient may feel severely dry, yet their test results look borderline.
So how do clinicians navigate that gap between subjective suffering and objective measurement?
We have to acknowledge the patient's experience while knowing that test reliability only truly improves as the disease progresses into moderate or severe stages. The tests are designed to quantify tear stability, production, and damage.
And there's a critical rule about the order of testing.
Yes, the order matters because the tests themselves can interfere with the results. Tests must be performed in an order that minimizes surface damage and tear disturbance. For example, the use of a diagnostic strip, like the Schirmer test paper, can scratch the surface and induce artificial reflex tearing, so it's generally done later in the sequence.
Got it. Let's start with measuring stability using the tear film breakup time, or BUT.
This is the fundamental test for identifying the failure of the lipid layer. The clinician applies a small amount of fluorescein dye and asks the patient to blink normally. Then, they measure the interval between the last full blink and the appearance of the first randomly distributed black spot on the cornea. That black spot is the tear film breaking, exposing the underlying epithelium.
And what's the benchmark for a healthy eye? What are we looking for?
Less than 10 seconds is considered suspicious for tear film instability. This test is crucial because it's abnormal in both aqueous deficiency and meibomian gland deficiency. It tells us the tear film structure is failing.
And there's a nuance about where the dry spot appears.
That's a great point. If the dry spots appear consistently in the same location with every measurement, that indicates a fixed local problem, maybe a minute elevation or irregularity in the corneal surface itself.
Right.
Not intrinsic tear film chemistry failure. If the spots appear randomly, that tells you the entire film is unstable.
Next, we measure production with a historical benchmark, the Schirmer test.
The Schirmer test assesses aqueous tear production by measuring how much a standardized strip of filter paper is wetted after 5 minutes, placed over the edge of the lower lid. It's cheap and accessible, but it's prone to variability.
I hear about Schirmer 1 and Schirmer 2. What's the difference?
So Schirmer 1 is performed without topical anesthetic. It measures the combined total of basic secretion plus reflex secretion.
Okay.
Schirmer 2 is performed after applying topical anesthetic, and the theory is that it measures only the basic resting secretion because the anesthetic blocks the sensory input that triggers the reflex.
Does the anesthetic fully block the reflex, though?
Unfortunately, no. The sources note that the anesthetic cannot completely abolish all sensory input, especially psychological or emotional stimuli. So the Schirmer 2 result, while useful, is not a pure measure of basal secretion. The results are highly variable.
It shouldn't be the only thing you use.
It should never be the sole diagnostic criterion. The thresholds are less than 10 millimeters of wetting after 5 minutes for Schirmer 1 and less than 6 millimeters with anesthesia for Schirmer 2. But again, you have to take it in context.
To assess the actual damage caused by the dry eye, we use ocular surface staining, and we have 3 main chemical reporters.
The easiest and most common is fluorescein. This dye enters tissue where there are epithelial defects or breaks in the tight junctions between cells, so it highlights general damage like punctate erosions and large corneal ulcers.
Then we have the one that causes the stinging, rose bengal.
Right. Rose bengal has a different target. It has a high affinity for dead, devitalized, or desiccated epithelial cells that have lost their protective mucus coating. It's excellent for highlighting filaments and mucus plaques, but the downside is real. For a patient who is already suffering from severe dry eye, applying rose bengal can cause intense, lasting stinging, sometimes for up to a day.
Wow.
So we have to use the smallest possible drop and often pre-treat with a topical anesthetic just to make the test tolerable.
That sounds like a terrible experience, which explains why clinicians prefer lissamine green.
Absolutely. Lissamine green stains similarly to rose bengal. It indicates cells lacking mucin, but it causes significantly less irritation. It's the preferred choice for regular surface assessment.
And the pattern matters.
The pattern of staining is also highly diagnostic. Interpalpebral staining, so in the area exposed between the lids, is highly suggestive of aqueous deficiency, whereas staining concentrated in the inferior conjunctiva is often seen with blepharitis or exposure issues.
Moving beyond the historical tests, the real breakthrough in objective measurement has been assessing the tear film's saltiness, osmolarity.
Tear film osmolarity is emerging as the most accurate diagnostic and monitoring tool
Why?
because it directly measures one of the 4 core mechanisms of the vicious cycle, hyperosmolarity. Instruments, often desktop devices, allow for very rapid, non-invasive collection of a tiny tear sample and calculation of the salt concentration.
This gives us clear, measurable thresholds. What are the definitive numbers we should know?
A value of 308 milliosmoles per liter, mosmol, is widely accepted as the threshold distinguishing a normal eye from a dry eye. Furthermore, values exceeding 316 mosmol are used to discriminate between mild disease and moderate to severe DED.
Why is this test so valuable if we already noted that symptoms don't always correlate with test scores?
Its value isn't necessarily in short-term symptom correlation, but in predicting treatment efficacy.
Oh, I see.
Osmolarity measurements correlate much better with the effective long-term response to treatment. If we can bring the osmolarity down below 308, we know we are effectively breaking the vicious cycle, even if the patient's discomfort hasn't immediately vanished.
What are some of the other specialized tests being used today?
We have the phenol red thread test, which is a quick 15-second assessment of tear volume that is less irritating than the Schirmer test.
Okay.
For research in very severe cases, we can perform impression cytology, where a small membrane touches the eye to capture cells. We can then actually count the number of goblet cells to assess mucus deficiency. And finally, tear constituent measurement involves assaying the tears for specific inflammatory markers like elevated matrix metalloproteinase 9 or decreased lactoferrin, giving us a highly specific picture of the patient's inflammatory state.
We have established the complex failure. Now we turn to the most critical section.
Yeah.
How do we try to fix it? The fundamental strategy has to acknowledge that the underlying causes of DED, especially in chronic inflammatory or autoimmune cases, are generally irreversible. We are not curing the disease, we're managing the symptoms and preventing progressive surface damage.
That mindset management over cure is essential for setting realistic patient expectations. We follow a tiered, graded approach laid out by the WS guidelines. The clinician only advances to the next level of intervention if the measures in the preceding level prove inadequate.
We start at level 1, education and basics. This is the foundation upon which all other treatments rely.
Level 1 begins with robust patient education. We need compliance and a full lifestyle review. This includes simple mechanical changes that counteract modern habits. For instance, advising patients to engage in forced, increased blinking while reading or using screens.
And crucial tip.
And a crucial tip: Orienting computer screens below eye level.
Why below eye level?
If the screen is below your line of sight, you naturally tilt your head down slightly and your eyelids close slightly more to view the screen. This minimizes the exposed area of the ocular surface, reducing the palpebral aperture size and drastically reducing evaporation.
Level 1 also involves reviewing every medication they're taking.
Absolutely. Eliminate or substitute any known contributory systemic medications and identify and eliminate toxic topical agents, especially preserved eye drops. Then we introduce replacement therapy, preservative-containing artificial tear substitutes, gels, and heavier ointments,
Right.
like mineral oil or paraffin, which are usually reserved for bedtime use due to the visual blurring they cause.
And what about managing the associated conditions?
Basic eyelid therapy is level 1, so warm compresses and hygiene for blepharitis or MGD, early reparative lid surgery for obvious structural issues like ectropion or entropion. Simple measures for nighttime exposure, like taping lids closed, are also level 1.
If level 1 fails to control symptoms, we escalate to level 2, non-preserved and anti-inflammatory agents. This is where we start attacking the vicious cycle directly.
The first major transition is in tear replacement quality. We move heavily toward non-preserved drops.
Why is that so important?
It's absolutely critical because if a patient needs to instill drops more than 3 or 4 times daily or has anything beyond mild disease, preserved drops become a source of toxicity, adding to the surface damage. Non-preserved formulations are always preferred.
And now we introduce the agents specifically designed to reduce inflammation.
This is the core strategy shift. We use topical steroids, but cautiously. They are typically low intensity and are used for short-term bursts to break an acute inflammatory flare.
But not long-term.
No, long-term steroid use carries risks like cataracts and elevated intraocular pressure, so we have to be extremely judicious.
So what's the long-term workhorse for inflammation?
Topical cyclosporin. This medication, sometimes known as Restasis or Cyqua, is a T-cell inhibitor. It reduces the chronic T-cell-mediated inflammation in the lacrimal and conjunctival tissue.
But it's not a quick fix.
It's not. It often takes months to achieve peak benefit, but it provides objective improvements, including an increase in goblet cell density, suggesting it is truly restoring function rather than just masking symptoms.
Systemic support is also key at level 2.
Indeed. Oral omega fatty acid supplements, specifically omega-3s, are strongly recommended. They reduce the overall inflammatory profile throughout the body and have a measurable positive effect on meibomian gland secretions,
Which can reduce the need for drops.
often dramatically. Additionally, we use oral tetracyclines like doxycycline, typically for 3 months, to treat associated blepharitis, as these drugs have anti-inflammatory properties that reduce tear levels of destructive mediators.
Level 2 is also where we start actively retaining tears, rather than just replacing them.
That's the introduction of punctal plugs. These are physical devices inserted into the tear drainage duct to physically reduce drainage and preserve both natural and artificial tears on the ocular surface. Other measures include tear secretagogues and external barriers like moisture chamber spectacles.
If levels 1 and 2 are insufficient, we proceed to level 3, highly specialized interventions.
Level 3 includes treatments such as serum eye drops. These are autologous, so they're derived from the patient's own blood serum or sometimes umbilical cord serum.
Why are they so effective?
They are vital because they contain essential growth factors, hormones, and anti-inflammatory components naturally present in the body that commercial tears just lack. They have shown profound benefits in severe cases.
But they're difficult to use.
They present logistical challenges. They must be refrigerated and have a limited shelf life. We also introduce permanent punctal occlusion and therapeutic contact lenses here.
And finally, level 4, major surgical interventions.
This is reserved for treatment failure and severe complications. It includes potent systemic anti-inflammatory agents administered by a rheumatologist, or major surgery like tarsorrhaphy, partially sewing the eyelids together to reduce aperture and evaporation, or using amniotic membrane transplantation to repair extensive corneal damage.
Let's take a deep dive into punctal occlusion, as it's such a clever mechanical solution for moderate to severe KCS.
The mechanism is elegantly simple. Block the drain to keep the moisture in. It works best when the primary issue is aqueous deficiency. The crucial clinical step is starting with temporary occlusion. Collagen plugs are inserted first, and they dissolve within weeks. This step is purely diagnostic.
Diagnostic.
We have to confirm that blocking drainage relieves the symptoms without causing a complication known as epiphora excessive, continuous tearing down the cheek.
If the temporary plugs work without the excessive tearing, then they can move to a long-term solution.
Correct. That involves moving to prolonged silicone plugs, which can be retrieved, or permanent solutions like thermal coagulation or cautery.
Is there a safety caution with that?
A major one. Clinicians must never occlude all 4 puncta at the same time. This prevents the possibility of complete tear retention failure and secondary infection risks. Complications include plugs extruding or migrating deeper, sometimes requiring minor surgical retrieval.
And let's address the dual contradictory role of contact lenses. They are listed as both a cause and a treatment for DED. How can that be?
It's the ultimate paradox. Chronic contact lens wear contributes to DED through inflammation, mechanical disruption of the tear film, and reduced corneal sensation.
Right.
However, therapeutic contact lenses can be a treatment. The lens can create a reservoir effect, trapping fluid behind the lens, constantly bathing the cornea.
And the high-tech lenses today are designed to exploit this.
Yes. Newer silicone hydrogel materials are specifically designed to retain moisture for extended wear periods. Even more advanced are occlusive gas-permeable scleral lenses.
How do those work?
These are large, rigid lenses that vault entirely over the cornea, resting on the white part of the eye. The space between the lens and the cornea is filled with saline, creating a constant healing, protective, and hydrating environment for even the most severely dry eyes.
Finally, what miscellaneous or futuristic treatments should we keep an eye on?
We have several advanced options. Botulinum toxin injection is sometimes used not for wrinkles, but in the medial canthus area to relax muscle tension, which can also reduce tear drainage.
Interesting.
For severe SS, the topical recombinant human nerve growth factor, Sjögren, is being investigated as a therapy to potentially regenerate the damaged nerve tissue on the ocular surface. And finally, photobiomodulation low-level light therapy is emerging as a promising, non-invasive method for treating severe meibomian gland dysfunction, improving that crucial lipid layer output. #tag outro.
This deep dive has truly laid bare the sophisticated engineering of the tear film and the destructive power of its failure. What we started with as a simple, uncomfortable, complaint-inadequate tears, we now understand as a self-perpetuating chronic cycle where hyperosmolarity triggers inflammation, which fuels further instability.
The foundational takeaway is that DD is not merely a lack of water. It's a failure of a finely regulated 3-layer system. And the critical insight that inflammation is present in 80% of patients is the reason that modern strategic treatments rely heavily on anti-inflammatory agents like topical cyclosporin,
Right.
rather than just basic ineffective aqueous replacement.
That's the actionable knowledge here. Start with the level 1 foundations. Screen orientation, better blinking, and eliminating toxic medications. But recognize that managing chronic DED means addressing the inflammatory cycle directly to prevent progressive damage.
And that strategic shift leads us to our final provocative thought for you to consider. We noted that the current standard treatment, artificial tear substitutes, often fall short. They're primarily aqueous-based, and they just can't perfectly replicate the complex 3-layer structure of the natural tear film. They lack the perfect balance of mucins, specific growth factors, and those dual-phase lipids.
So the question is,
Given the immense resources being poured into ocular material science, what technological leap-in, biomimetic chemistry, or nanostructure design will be required to finally create a truly integrated 3-component artificial tear film, and when might that breakthrough fundamentally change the quality of life for the millions suffering from chronic DED?
a fascinating challenge that requires solving a huge chemical and engineering puzzle. Thank you for guiding us through the mechanics of the ocular surface today.
My pleasure.